In the next 15 minutes, I'd like to give you an introduction to Lantheus Medical Imaging with a focus on Polarify or pflufolastat F18, a PSMA imaging PET agent that's recently approved by the FDA to help in the management and the treatment of men with prostate cancer. Although new to urology and prostate cancer specifically, Lantheus is not a new company. Lantheus was founded well over 50 years ago, and it is publicly traded on NASDAQ with a number of commercially marketed products across a number of therapeutic areas and therapeutic disciplines. I'm sure that some of you in the audience are familiar with a version of this slide reporting on the incidence of solid tumors in the United States. For 2021, on the left, you see that prostate cancer is at the top of the list of sites of new cancers being diagnosed, with an estimated 250,000 men expected to be diagnosed with the disease this year. What you see below the tables is that the 5-year relative survival rate for men with prostate cancer is about 98%. So most men with prostate cancer will be alive 5 years after diagnosis. And this has led to the notion that prostate cancer is an indolent disease and part of aging, and sort of an inevitable part of aging. On the right hand, however, you look at the table that describes the leading sites of cancer death in the United States. Although not at the very top, prostate cancer is number 2, with an expected 35,000 men dying of prostate cancer this year. Now, that's for prostate cancer, an indolent disease. If you go down a couple of rows, you'll see that pancreatic cancer, widely regarded and understood to be a uniformly lethal disease, will take the lives of about 25,000 individuals in the same time period. So just contrast this. Prostate cancer, an indolent disease, will be responsible for 35,000 deaths this year, whereas pancreatic cancer, a lethal cancer, will take 25,000 lives this year. And that's one of the things that I want to focus on this evening, is that we need to focus on impacting the survival rate of men with prostate cancer by better diagnostic imaging, by better approaches to treatment, and improved management of the disease. Here we see a graphic depicting what we call the patient journey, or the natural history of prostate cancer. I often refer to this slide as the roller coaster slide. And in fact, the journey of many patients and many men with prostate cancer is a roller coaster, with PSA going up, then responding to treatment, going down, only to go up again and down and up again. But there are some stark realities behind this graph. What you see on the left is, as the initial PSA goes up, men are biopsy diagnosed with prostate cancer and are offered local therapy, primarily radical prostatectomy and or radiation therapy to treat the disease, assuming that it is confined to the prostate. So the intent of this surgery is to cure the disease. The stark reality is that in this country, somewhere between 40 and 50% of men who undergo surgery with radical prostatectomy or curative intent radiation therapy will not be cured, and in fact will have a recurrence of the disease manifest by an elevated or a rising PSA within the first 5 years. Those patients will typically get some sort of salvage therapy, and often will get hormonal therapy. Hormonal therapy is never curative. And again, the stark reality is that all men who start hormonal therapy, if they live long enough, will become resistant to that hormonal therapy, or what we call develop castrate-resistant prostate cancer. Additionally, all men who develop castrate-resistant prostate cancer if they live long enough, will develop metastatic prostate cancer. And all men who develop metastatic prostate cancer, if they live long enough, from competing causes of death like heart disease, emphysema, stroke, diabetes, and hypertension, if they live long enough, all men with metastatic prostate cancer will succumb to the disease and die of prostate cancer. So the question is, why did these patients fail? Is it because surgery is not curative? Is it because radiation does not kill the cancer cells? And I believe the answer is no. It is not dependent on the technology. It is dependent on patient selection. So we need to do a better job at staging patients, both at initial presentation as well as if and when the disease recurs. So let's take a look now at PSMA PET imaging and its potential role in the management of men with prostate cancer. Polarify, or piflufolastat F18, also known in the past as 18F-DCF-PYL or simply PYL, is a radioactive tracer that is injected into patients. It binds to PSMA on the cell surface of the prostate cancer cell and therefore can be imaged by what's called a PET or a positron emission tomography camera. It was developed at Johns Hopkins just over 10 years ago. Patients come into the imaging suite, they're injected with the agent, and then they lay down on the PET camera or are imaged on the PET camera about an hour to 90 minutes post-injection. In the middle, you see the molecular structure of DCF-PYL or piflufolastat, and in the green bubble off to the left, you'll see the 18F fluorine. That's the radioactive portion of the molecule that can be picked up by the sensors in the PET camera. On the far right, you see a PET image of a patient who does not have prostate cancer. This is the normal, so-called normal biodistribution of PSMA tracer, and you see it's expressed and picked up in the lacrimal glands behind the eyes, in the parotid glands on each side of the jaw, in the submandibular glands beneath the jaw as well, and also in the liver, and it's very highly expressed and taken up by the kidneys, excreted in the urine down to the bladder, and there is some expression also in the small bowel. So whenever we're reading a PSMA PET scan and we see these areas light up, these are considered part of the normal biodistribution of the agent and not suggestive of metastatic disease. To further elaborate on the role of PSMA for prostate cancer imaging, take a look at the graphic in the middle of this slide. The green globe in the middle depicts a prostate cancer cell, and on the left side is a normal or a benign prostate cell or prostate tissue. And what you see is that in the normal situation, the PSMA protein is internal. It's in the cytoplasm or the inside of the cell. But for reasons that are not fully understood at this time, is that this protein, the PSMA protein, migrates to the outer surface of the cell during a cell's dedifferentiation or malignant transformation. So as the cell mutates from a normal prostate cell to a cancerous cell, the PSMA protein migrates to the outside of the cell, and the more aggressive the tumor, the more of this protein is expressed on the outside of the cell, making it an ideal target to try and bind a radioactive agent to help image the cells that express this protein on the outside. So this is the way I simplistically think about this. The target is PSMA on the surface of the cell. Piflufolastat is the key that locks that onto that target. And on that keychain is hanging an F-18 molecule, which is radioactive, so that it can help you find the key that's locked onto the target. Manufacturing agents like Polarify and getting a dose to the patient is not simple. It is very complicated and somewhat tricky. Remember, these are radioactive or radio emitting agents that have a half-life of about 2 hours. So the raw material is brought in, is then shipped off to PMF sites. PMF stands for Pet Manufacturing Facilities, which are essentially cyclotrons scattered throughout the country because the doses have to be made locally within a 2-hour or 2.5-hour radius of an imaging center. So the pet manufacturing site or the cyclotron makes the agent. It is then shipped, typically driven, although sometimes we do fly doses, to an imaging center somewhere within a 200-mile radius of that cyclotron, and then the patients are scheduled to come in for imaging. So now let's take a look at some of the data that supports the use of Polarify and the indication that was approved by the FDA. This is an actual screenshot of the FDA-approved label or indication statement for Polarify or piflufolastat F18. And I'll read it to you. The indication for Polarify is indicated as a radioactive diagnostic agent for PET imaging of PSMA positive lesions in 2 groups of men with prostate cancer. The first group is at the initial presentation of men who are thought to be at risk for metastases prior to initial definitive therapy. So this is what we call part of the initial staging of prostate cancer. The second group of men is those men who have had previous therapy but now have a recurrent or rise in their PSA or persistence of their PSA that's elevated following previous therapy, indicating that they have either persistent or recurrent disease. So it is a broad indication that covers both men at the initial presentation as well as men subsequent to prior therapy with prostate cancer. As with all medications, we have to be aware of some safety information. There are no contraindications to Polarify scanning. There is always the risk of image misinterpretation. These images are read by radiologists. They're not perfect, or nuclear medicine physicians who are well trained, but again, not perfect. The scan itself is not perfect. It cannot pick up a single cell, a single malignant cell, for instance. So there is the potential for false positive as well as false negative examinations. Polarify is an injected agent, so just like any other injected drug, there's always the risk of an allergic reaction. But again, remember, this is administered in imaging centers, either freestanding or in a hospital setting, that are typically well equipped to deal with those kind of instances should that occur. Radiation risk is also associated. It is a radioactive agent, but again, the cumulative risk of radiation is quite small. Adverse reactions or side effects were rare in the clinical studies, and less than 2% of patients complained of either headache, dysgeusia, which is kind of an altered or metallic sense of taste, or fatigue. All of these were transient, and resolved spontaneously without any intervention. As we saw before, Polarify or piflufolastat has a very broad label from the FDA covering essentially the spectrum of prostate cancer. And this was based on studies that were submitted to the FDA to support approval of the agent. There were two studies that were conducted, Osprey, which had two cohorts, cohort A assessing the performance of the agent in early or localized, clinically localized disease, and Osprey cohort B, which assessed the performance of the agent in advanced disease in the castrate-resistant or hormone-resistant space, including patients who had failed first, second, and even third line of therapies. And then the Condor Study, which looked at the very early recurrence following failed surgery or radiation therapy with patients who have what we call biochemically recurrent disease. We'll now take a quick look at each of these studies. The Osprey study, which is published in the Journal of Urology, again assessed the performance of the agent at patients being evaluated for radical prostatectomy, so in the initial staging of the disease. And what you see in the graphic in the lower left is if you look at that maroon and the orange colored bar that represent the positive predictive and negative predictive value of the agent, they're both extremely high. The positive predictive value predicts the likelihood that the patient has nodal metastases at the time of diagnosis, compared to surgical pathology, and likewise the negative predictive value predicts the likelihood that the patient does not have disease, again confirmed by surgical pathology. Now, what you see is an image on the right side. This is a patient who was seen by a urologist, had conventional imaging, CT scan, MRI, bone scan, and you see the bone scan here, which is negative. And based on a negative workup, he was planning on radical prostatectomy for treatment of the disease. But he had a Polarify scan, and what you see on the right, and we'll take a closer look at this patient in a couple of minutes. He has extensive disease, both nodal disease as well as osseous or bony metastases that was not picked up by conventional imaging. And again, this is a patient who would not benefit from either local surgery or local radiation because at the time of presentation, he has, based on Polarify scanning, he has evidence of widespread metastatic disease. On the previous slide, we looked at the performance of Polarify compared to surgical pathology, but here we're looking at the performance of Polarify against conventional imaging in patients with high-risk prostate cancer scheduled for radical prostatectomy with pelvic node dissection. So in Condor A, there were 268 patients included. They all underwent conventional imaging with MRI, CT scan, and bone scan. And out of those 268 patients, conventional imaging was able to pick up 10 patients who had radiographic evidence of disease outside of the prostate. 9 patients suspected to have pelvic nodal disease, and 1 patient who was suspected to have disease outside of the pelvis, or so-called distant metastatic disease. So about 4% of patients were thought to have disease outside of the prostate. But in this same population of men, Polarify scanning identified 33 patients with disease outside the pelvis and 51 patients with evidence of pelvic nodal metastases. So as opposed to the 4% picked up by conventional imaging, Polarify scanning picked up 34% of patients who were suspected to have disease outside of the prostate. Now I remind you when we started this discussion that I made the statement that in this country about 40% of patients who undergo surgery or radiation therapy for cure of the disease will fail the disease and have evidence of PSA recurrence. So if at the time of diagnosis, we see that 33 or 34% of these patients already have evidence of disease outside of the prostate, it should be no surprise that about 40% or maybe even higher, 45% of patients will fail primary therapy and present with a PSA recurrence sometime within those first 5 years. The second study, the so-called Condor Study, looked at the performance of Polarify PSMA scan in men with biochemically recurrent prostate cancer. These were men, 217 patients were included or consented for this study, had all undergone either radical prostatectomy or radiation therapy as primary management of their disease. All of these men achieved a good response to the initial therapy, but had a recurrence of the PSA as evidence of recurrent disease sometime after the therapy. All of these men were initially evaluated by conventional imaging, and again that included CT scan, MRI, bone scan, and in this instance also fluciclovine or Axumin scanning. And all of these men had negative or uninformative conventional imaging, so that the treating physician was faced with a patient who has evidence of recurrence disease, but the imaging studies did not pinpoint the site or the sites of recurrence. So the question is, how do you treat these patients? Because you know the disease is back, you just don't know where it's coming from. So all of these men then underwent a Polarify PSMA PET scan. And what you see is that in the lower left is the CLR, which stands for correct localization rate, across a variety of PSA thresholds, from very low PSAs less than 0.5 to high PSAs over 5. The median PSA for this group of men was actually quite low, it was 0.8. So these are patients who are presenting with very, very early recurrent prostate cancer. And as in all diseases, the goal is to treat early, because early treatment tends to have better long-term outcomes than waiting till the disease is more advanced. So again, what you see here again is excellent performance by Polarify with correct localization rates across all PSA thresholds, from the high 70% to as high as the high 90%, regardless of PSA levels. And again, I remind you, all of these patients had uninformative or negative conventional imaging. So the data from both the Osprey and the Condor studies clearly supported the performance of Polarify PSMA PET across the spectrum of prostate cancer. But the question is, what do I do with this information, and does it make a difference? So the question is, so what, and why should I care? Because ultimately, does it impact what I do, or how I manage the patient or advise the patient in terms of the management of their prostate cancer? Let's take a look. As part of the Condor study in the biochemically recurrent patients, the physicians were given a questionnaire before and then after they saw the Polarify report to indicate how they would manage that patient, or what treatment would they recommend that patient before Polarify scanning and then afterwards. And then we took a look to see if it actually made a difference in the change of management of these patients. And we can take first sort of the high 30,000 foot view. Now, when we take that high or 30,000 foot view and ask the question, does it actually change patient management? The answer is clearly yes. And it's a pretty emphatic yes, because when we examine those questionnaires, 64% of patients, that's essentially 2 out of every 3 patients, would have had a change in management based on the Polarify scan compared to the recommended management based on conventional imaging. So that was the first question. Does it change management? And the answer is clearly yes. In 2 out of 3 patients, it led to a change in management recommendation. The second question, or overarching question, is it just positive scans that lead to a change in management, or do negative scans also have some sort of clinical utility and value in patient management? And again, the answer is yes. And what we saw when we compared these questionnaires on patient management, that in fact, the majority of the changes, 80% of the changes, were based on positive PSMA Polarify scans. But it's also important to note that 20% or 21% of 1 in 5 men had a change in management who had negative scans. So both negative as well as positive scans can have a role in patient management decisions. As we saw on the last slide, 64%, or essentially 2 out of 3 evaluable patients, had a change in intended management following Polarify PSMA PET scan. There were these broader groups of changes. So there were about 20% of men changed from systemic therapy to salvage therapy. About 28% went from salvage local therapy to systemic therapy. Some patients went from proposed therapy to observation, in other words, withholding therapy and just following the patients along. And then again, a number of patients who were recommended observation based on negative conventional imaging, once they saw the Polarify scan, were recommended intervention or therapy. So again, we see these kind of big, broader buckets of change based on Polarify scanning. Now, if we really take a close look, the so-called 500-foot view, I think it really shows the potential on the potential ability of PSMA PET, or so-called next-generation imaging, to impact treatment recommendations and patient management. This slide is a little bit busy and a little bit complicated, but I'll try and take you through it. You see 2 graphics on the left side and one on the right side, each with a single bar on the left and another bar on the right. What you notice is the bars on the left in each of these are identical. So these are patients from a study that was published out of Switzerland of about 300 patients who were managed initially without PSMA PET and then were looked at with PSMA PET to assess the impact on management recommendations. The left side on the left bar in each of these images is the initial therapy recommendation. Okay, so the majority of the men underwent radical prostatectomy, which is the orange color on the left side on each of these bars, and then or radiation therapy, which is the green bar. And that's the same for both, because that was the initial management of these patients. Now, all of these patients had biochemical recurrence. In other words, they failed their initial therapy, had PSA recurrence either after surgery or after radiation therapy or some combination. And the left side, you see the treatment options according to the standard guidelines without PSMA PET, so just based on conventional imaging. And what you see is essentially all the men who in the orange who underwent radical prostatectomy go to some form of radiation therapy as their next line of treatment. All the patients, or the majority of the patients who had radiation therapy, now as a broad swath move up and are recommended to have androgen deprivation or hormonal therapy based on guidelines. So that would be the standard recommendation. Now look what happens when you introduce PSMA PET. So instead of having these kind of broad swaths of changes where almost everybody who has radiation goes to hormonal therapy and almost everybody who had surgery goes to radiation therapy, you see all kinds of different management recommendations from combination therapies to intensification of therapy, multimodal therapy, etc. And I think what you see is, or at least what impresses me here, is that incorporating PSMA PET now leads to much more options into management decisions, provides patients with much more individualized treatment options to optimize their care and to hopefully improve their outcomes. So in closing, I'd like to present just a couple of cases to illustrate the utility of Polarify or PSMA PET scanning in prostate cancer, because as they say, a picture is always worth 1,000 words. This is a little bit of a more detailed look at that patient we saw earlier from the Osprey cohort. 63 years old, a PSA of 7 with Gleason 9 disease, and MRI showed extracapsular extension with some seminal invasion. So he is high-risk prostate cancer, but despite the advanced local disease, his bone scan is totally negative. But look at the Polarify scan or the PSMA scan on the right. Again, as I mentioned earlier, this unfortunate patient presents with widespread metastatic disease in his long bones, in his thoracic spine, in the sternum, as well as some soft tissue metastases in his lymph nodes. Again, demonstrating the profound impact that Polarify scan can have on management recommendations or treatment recommendations and management with men at the initial presentation with prostate cancer. The second case that we'll look at is from the Condor Study, and this is a 70-year-old gentleman who underwent radical prostatectomy in April of 2018 for a high Gleason score, Gleason 9 disease. His postoperative PSA was undetectable, and it was felt that the surgery was curative. However, just over a year later, his PSA is 0.7, again, indicative that he has recurrent prostate cancer. Conventional imaging was negative and included bone scan as well as pelvic CT. So based on the fact that he has recurrent disease, but the conventional imaging is negative for any disease outside, his recommended treatment would have been radiation to the pelvis with some boost to the area of the prostate and plus some short-term hormone therapy to improve the efficacy of the radiation therapy. Now remember, his recommendation was to radiate the pelvis because it was suspected that with the high-grade disease that was the most likely site of recurrent disease. But this is his Polarify PSMA PET scan. And what you see is the bladder, which is contains urine, but there's no evidence of disease in the pelvis outside of the area of the bladder there. There's no evidence of any nodal disease or any persistence or recurrence in the area of the prostate. But what there is, as the arrows point out, is an isolated metastasis in what appears to be the thoracic spine in the middle of his back. Again, this is quite surprising and unexpected with a patient with a PSA of 0.7 because typically we think that bony metastases occur at much higher PSAs in the 20, 30, 40, or even higher range. And just to verify that the Polarify scan is identifying a potential lesion within the spine, a focused MRI examination was done, which again shows this sclerotic lesion within the thoracic spine consistent with metastatic prostate cancer. The patient, instead of getting radiation to the pelvis, which would have been ineffective, got stereotactic body radiation or focal radiation to the thoracic spine, and I'm happy to report that immediately after the radiation, in other words 6 weeks after the radiation, his PSA went to undetectable levels. So we come back to the so-called roller coaster slide. And what I've highlighted here, based on the studies, based on the FDA indication, and based on the information we have, is that we believe that Polarify PSMA scanning should be part of the workup and evaluation of men at presenting with high-risk prostate cancer as part of their initial evaluation for definitive therapy that you see here in the purple circle, as well as men who have PSA elevation after failed prior therapy, be that surgery, radiation, hormonal therapy, or chemotherapy, as outlined in the red circle. And I think that the information, if we incorporate the information that we learn from the molecular scanning, the PSMA scanning, we'll be able to make better, smarter decisions and treatment recommendations. I always believe that more information is better than less information. And I think that what we will see is progress in the management of prostate cancer. And although we don't have the data yet, I firmly believe that better treatment leads to better outcomes. Thank you for your attention.